Today's symposium is both a culmination and a celebration of your many wonderful achievements in this important area of healthcare. Here at the School of Medicine, I want you to know that we are very proud of your accomplishments, and we look forward to your continued growth, as well as many more opportunities for continuing collaboration. We're very proud of this day. We hope you have an exceptional experience, and we're delighted to have you here. And thank you for allowing.
But fundamentally, because need is not fully met by conventional medical practice. So again, the conundrum we face as we commit ourselves to what clearly is one of the prevailing mantras in modern medical education, evidence-based practice. The conundrum is, what do we do when the evidence we have learned, or perhaps, if we care to be more provocative, with which we have been indoctrinated, does not fully meet the needs of our patient? What do we do then? Well, we know some years ago, the CDC funded us to the tune of $1 million to do what they referred to initially as a systematic review of the evidence base of complementary and alternative medicine. Anybody who's ever been involved in a systematic review knows that's a very silly thing. Systematic reviews are directed by narrowly framed questions you try to answer. This was silly. Well, we knew it was silly, but on the other hand, $1 million sounded good, so we said, sure, we took the money. And then we figured we'd figure out what to do with it, which is what. There are many examples of this, but the one I like best is coenzyme Q10 versus carvedilol. You look down at the bottom of the slide, and the citations are there. The final nail in the coffin of the CoQ10 might be good for heart failure hypothesis theoretically was driven in the year 2000 when this paper by Katz et al. Was published in the Annals of Internal Medicine. Now I say it that way because I don't believe that was the case. But here was the trial that proved that coenzyme Q10 or ubiquinol does not work in congestive heart failure. 55 men with congestive heart failure, randomly assigned to CoQ10 or placebo, followed for 3 months for change in left ventricular ejection fraction. At 3 months, when there was no statistically significant difference between groups in LVEF, the conclusion was reached: CoQ10 lacks efficacy for heart failure. At around the same time, a year later, the article was published in Lancet that made carvedilol a mainstay in the treatment of congestive heart failure. Carvedilol, as many of you know, is an alpha beta blocker. This trial involved approximately 2,000 people who were followed for years for definitive coronary events and death. And the groups diverged. Carvedilol was clearly superior to placebo, and consequently carvedilol is a mainstay in the management of this condition. CoQ10 is not. So in the one case, the definitive trial was 55 people in 3 months. In the other, the definitive trial was 2,000 people in years. That's not fair. And again, we come to the issue that absence of evidence is not necessarily evidence of absence. We have never seen the definitive trial of CoQ10, which, by the way, on the basis of anecdote, if nothing better, I do believe offers benefit in congestive heart failure, a number of other conditions as well. There's this claim that this infusion of calcium, magnesium, B vitamins, vitamin C ameliorates the symptoms of fibromyalgia. Can you give me any hint as to why that might be? And for the most part, the answer was no clue. So we submitted a grant, but we did a typical randomized placebo-controlled double-blind trial for several months. This was a pilot study, an R21 grant. And 40 subjects were randomized to one of the 2 treatments, and you see here some of the standardized assessments we used. The TPI, or tender point index, is fairly customary in assessing fibromyalgia. And we looked at the results immediately post-treatment and followed them out a couple of months. And the results are currently under review. What I can say is we saw improvement in both our treatment and our placebo group, the magnitude of which was greater in both groups than is typically seen with Lyrica, the one FDA-approved drug for fibromyalgia. Now, We're studying fibromyalgia. We're studying the effects of phytoestrogens on symptoms of menopause. We published a really nice paper recently in the Archives of Internal Medicine, massage therapy for osteoarthritis of the knee. We saw residual benefit of the course of massage 8 weeks after the last massage, and we're now pursuing the R01 study where we'd like to show that this deserves to be a mainstay in the treatment of osteoarthritis. We have looked at yoga as adjuvant therapy for asthma. Didn't work. I'm not sure that it says anything about yoga except that it's rather hard for people to do it consistently, and so the practical utility was not demonstrated, although I think the physiologic effects of yoga deserve further investigation. We've looked at homeopathy for attention deficit disorder in children. We've looked at biologics as well, done reviews of a number of nutrients for affective disorders and so forth. Quite a few of them in the room. I think we have to look beyond the results of RCTs in order to address patient need today. And to do that, I invite the use of a more fluid concept of evidence than many of us have imbibed from our medical educations. And we don't want you on narcotics any more than you want to be on narcotics. We initiated a course of acupuncture. Over the next 2 to 3 months, weaned him off narcotics. He was pain-free on acupuncture, and subsequently transitioned into homeopathy. Now, I don't care to get into a discussion of how or even whether homeopathy works, but here we were in a situation where this guy had tried everything. And the anecdotal evidence that homeopathy might be effective was brought up by the naturopaths. We tried it. It worked. We followed him for years. Since we've last seen him, he's pain-free. Now, this might seem coincidental until you recall he had 10 years of unremitting pain when he came to us, and within approximately 3 months of coming to us, he was pain-free and remains that way. We know, for example, that most of the reviews in antioxidant supplementation indicate that they are ineffective. We're very excited about folate and B12 to suppress homocysteine. I trust you know they do that, but the evidence shows they don't reduce the incidence of cardiovascular events. The NIH not too long ago held a consensus conference on the use of multivitamins, concluding that they couldn't conclude anything. We don't know whether or not. And so I would argue here, too, is an invitation to think more fluidly about evidence. Absence of evidence is not evidence of absence. We have a rich literature